For this last session of the Covering Rare Diseases Fellowship Program, we arrive at the point that really is at the heart of this issue, and that is patients and their families. Our panel discussion will be about patient advocacy, and the goal is, as we've discussed over the past few days, normalizing rare diseases or getting the conversation to a place where the entire society understands it and empathizes with it. We're joined by Britta Dornan. She's the Senior Director of Communications and Marketing with the EveryLife Foundation. We're also joined by Durhane Wong-Rieger, President and CEO of the Canadian Organization for Rare Disorders, and Christine Mutena, the co-founder of Rare Disorders Kenya. Britta will be leading the panel discussion and the conversation around the issue of patient advocacy, and I'm really looking forward to hearing their input. So Britta, please take it away.
Thank you, Rachel. Good morning, good afternoon, good evening, wherever you may be. My name is Britta Dornan, and I just want to first thank all of you for committing to this 3-day conference and for your curiosity and commitment in covering rare diseases. I like to say that an oft-forgotten partner in rare disease advocacy is the media. Journalists, you are key to reaching audiences from policymakers to patients like myself to public healthcare workers. And in fact, I conduct trainings to teach our advocates on how to reach out to members of the media, how to identify the right journalists to reach out to, how to pitch their stories. So today, our goal is to get your wheels turning so that as you're working on your stories, to consider the patient advocate component and remember the human aspect of rare disease. And for you to see us, Durhane and Christine and myself, as resources for you. So as you think about patient advocacy today, keep in mind that without patient advocacy, without the patients and parents and family members who are affected by rare disease, almost none of the advancements and the accomplishments that you've spent the last 2+ days learning about wouldn't have happened. So today I'll share with you about the patient advocacy organization for which I work, my story quickly as a patient advocate, and a quick level set on what is patient advocacy. And I'll introduce my fellow panelists and we'll chat. We have a few topics that we think will be of interest to you that we're going to talk about this morning. So let me share my screen. So the EveryLife Foundation for Rare Diseases, that's the organization that I am with. And if it sounds familiar to you, it may be because you met our founder, Dr. Amo Kakis, and you also met Annie Kennedy, who is our Chief of Policy Advocacy and Patient Engagement, earlier this week. So if you visit our website using that nifty QR code, you can learn more about us, but we're all about empowering the patient advocates so that they can make their voices heard to advocate for science-driven legislation that advances the equitable development of and access to life-saving diagnosis, treatment, and cures. So you'll see that we are very focused on closing the innovation gap, eliminating the diagnostic odyssey, improving the regulatory process, ensuring patient access to therapies and cures, and all that is done through empowering the patient voice. We do not speak for patients. We don't tell them what to say. We give them the tools and resources to make their voices heard, because we are a public policy organization, but we fully understand that public policy only gets pushed through because the patients make their voices heard. So how did I come to join this incredible organization? My patient advocacy story goes from being an actress to becoming an advocate. Many moons ago, I was an actress living and working in New York City and traveling the country performing Shakespeare until I developed a rare disease called primary lymphedema. And it first presented when I was 13 years old. And primary lymphedema impacts the lymphatic system. The lymphatic system is pretty important to life itself. And so when it fails, it can be life-threatening. And for me, it causes swelling, intense swelling and pain that if it were not to be controlled, I wouldn't be able to stand up and do this and speak to you today. And it would be threatening to my life. It took me 10 years to find out what it is that I had exactly. And throughout my career working, I shifted from being an actress to working in public service. And throughout that time, I didn't talk about my rare disease. I was too afraid of the consequences or the stigma or the impact on my employment until I had a wake-up call about 10 years ago when I had a attack by 2 dogs that bit up my legs and sent me to the emergency room. And it was just a big wake-up call for me that I did not want to, I felt in the moment that I was scared and I felt like a victim, and I did not want to feel that way anymore. And it was a turning point for me. It was a wake-up call. And within 2 weeks, I started my blog, Lymphedema Diary. And it wasn't long before, in those several years later, that I sought out the EveryLife Foundation. I wanted to join an organization where I could help other rare disease patients like myself. So that's my patient advocacy journey in a nutshell. So what exactly are we talking about when we say patient advocacy? What is advocacy? Advocacy is simply storytelling with a purpose. You can tell your story all day long on Facebook or to your family or whatnot, but when you tell it with a purpose, then it becomes advocacy. And these are just a few examples of the many thousands of rare disease patient advocates that we have in the United States. And the advocate on the left, for example, uses her voice and tells her story to advance telemedicine options and to keep them and to continue them in place as we emerge from the COVID crisis. The second patient advocate, as you see in the middle, they are using their voice and telling their story because they want a rare disease center of excellence at the FDA created so that we can develop treatments faster. And the advocate on the right tells his story about his 2 children who have rare disease because he wants to push for strengthening and protecting our newborn screening programs. So these are examples of real life advocates who tell their story with a purpose. But rare disease advocacy, patient advocacy, can be traced back many decades ago. And for us in the United States, 40 years ago, really was a big flag planted. And that was with the passage of the Orphan Drug Act of 1983. And it was the first time that, that a celebrity was used as an advocacy tool on Capitol Hill and that's what helped pass the Orphan Drug Act. And this is documented in the book that's pictured there by Abby Myers. I highly recommend it. It's quite a dramatic story, and coming up on the 40th anniversary of the ODA, I think it might be a good opportunity for you to learn more about it. But in a nutshell, there was at the time a Hollywood writer and producer named Maurice Klugman who suffered from a rare cancer, and her brother happened to be Jack Klugman, who is the star of a popular series at the time called Quincy M.E. And so that is Jack Klugman pictured on the right with Abby Myers in the middle, and of course his Odd Couple TV star Tony Randall on the left. And so Maurice asked her brother to testify and participate in advocacy, and thanks to that celebrity and the work of many, many grassroots patient organizations and individuals, it passed. And that was actually the impetus of NORD that I know you know about, the National Organization for Rare Diseases. So the Orphan Drug Act has been critical here in the United States. It provides a 7-year market exclusivity and up to 50% tax credit for research and development expenses. So it's been incredibly successful in that it's enabled more than 600 drugs and biologics for rare diseases to come to market since 1983, when by contrast, fewer than 10 came to market in the decade prior to the ODA. So it's been incredibly successful, and yet it has been under threat here in the United States, which is why we have had to continue to make our voices heard as patients. That tax credit has been cut in 2017. So in the years that have followed the Orphan Drug Act passage, we have witnessed patient advocacy rise to a level in the United States never before seen. And in particular, I'd like to flag the HIV/AIDS movement. These images may look familiar to some of you. They were quite dramatic at the time. The patients at that time were fighting to make their voices heard because they were dying. They were demanding faster development of treatment and felt that they were being failed by the government and by the FDA. So they staged these demonstrations, and it was nothing that we have seen before in the patient community. And it led to passage of more critical legislation, such as the Prescription Drug User Fee Act, or PDUFA. And that was groundbreaking. It led to the FDA, Congress, and industry to work together to shorten drug review times by introducing that user fee that allowed the FDA to expand their resources. So this is so critical. I point this out because we have learned from this in the rare disease community, what they did. We learned that an educated and activated patient community are effective and powerful change makers. So today, advocacy looks like this for us in the United States. This is our Rare Disease Week on Capitol Hill. This is many, many advocates from a couple of years ago. And this is one way. We still go to Capitol Hill. We still go to DC. And we are planning to go back on Capitol Hill to make our voices heard this February 28th through March 2nd, 2023. And advocacy looks like this. It also looks a lot of different ways, with advocates working from home and sending action alerts, so the click of a button and making a phone call or sending an email. And so now I would like to introduce, I'd like to stop sharing my screen, and I'd like to introduce Durhane so that she can tell you about her patient advocacy story, her organization, and a bit about what patient advocacy looks like for her. Durhane? And Durhane, be sure to unmute yourself.
No, we did. Thank you very, very much. That was a great introduction, Britta, and certainly gave us a snapshot for patient advocacy in the US, but also obviously the impact globally. So I am Durhane Wong-Rieger. I'm president here in Canada, but I also, I think, as many of you know, I also serve as chair of Rare Diseases International, which is our global alliance of rare disease patient organizations. So representing probably about 120 so countries around the globe. And a lot of the advocacy we do is also with regard to global policy, but also working with many of the other countries and patient organizations there. But I think, as Britta says, many of us in the rare disease community start with our own personal experiences. A lot of patient advocates. I have two children, both of whom were born with rare conditions. My daughter had a rare disease condition that was obvious at birth, but has never been diagnosed. And my son was actually born with a rare heart condition, was diagnosed immediately. And of course, totally different pathways with these two children. I will have to say also, both of them were adopted. So we adopted them as special needs kids. And so we were aware that we were going to have, sort of talk about being an advocate, right? You're a parent advocate right from the start. And with my daughter, it was always a matter of trying to figure out what to do next, what was going to happen, because we had no roadmap. We had no ability to get a diagnosis. And at that time, genomics was not what it was. We were not able to do a diagnosis without her birth parents. With my son, we knew every step along the way what it was he should be doing. And in fact, he got brilliant care. And Canada's a great country for getting that. But, by when he hit 18, as with many patients, not even just rare disease patients, the system changes because there's not that continuation from pediatric care in many cases to adult care. And that's still what's happening in the rare disease world. But I will say that my entry into patient advocacy actually came from a very different direction, because I'm a psychologist by training, was teaching at university, a full-time professor. And I had a colleague who came to me, she had a son with hemophilia. And at that time, it was during the whole tainted blood issue. Britta, you showed the HIV. Those were those early days, right? When suddenly all the patients with hemophilia who had been infected, through the blood products took on, absolutely following the other HIV patients, a strong advocacy role in the US. Globally, people were really up in arms, first of all, because they had been so unprepared for the fact that the blood products they were being given, which they thought were this miracle to allow them to kind of continue to be able to work and to infuse at home. And suddenly for the first time, you had patients who used to be in hospital, 2 or 3 days a month getting, plasma transfusions, now being fully mobile. Many of them have young parents. They'd gone to school. And suddenly they realized they had HIV. And guess what? Nobody took responsibility. Nobody. And most of them, because they were hemophiliacs, had no insurance. And suddenly you had fathers, children who didn't have, have a life expectancy. So I actually came in because I was asked, can you come and help us? Can we get, and in Canada, what we wanted to get was compensation from the government. How can we get support for these men, young men, even some boys, right, who have been infected? So that was kind of my entry to it. And we actually did some amazing things in Canada, including getting a royal inquiry called, which would be like a commission on getting to the truth. We ended up being able to get not only compensation for the patients with that were infected with HIV, we got compensation for those who've been infected with hepatitis C, which turned out to be a huge issue with regard to transfused blood that had hepatitis C in it. Over $1 billion, class action suit. We got a whole new blood system brought in, took out the Red Cross because we really felt that they had compromised their integrity in terms of continuing to distribute contaminated blood, when in many cases it was known that it was in fact, contaminated. So that was kind of my entry into it. And as I said, I got into it, it was very much kind of felt really empowered by the fact that we can make huge policy changes. As you say, it's not just kind of we did a lot of important things for individuals, but also what we learned from there is one, is that you got to have, let's just say, a message. You got to know what your message is. Two, we actually had to have a community response. So not only hemophilia, which was tough because about, half of the population was infected, half not. We had parents with young kids who didn't want to talk HIV at the time, whose kids were already being, discriminated against in school. And yet we had to encourage them. You got to remain involved. You've got to stand up for the whole community and to be able to fight together. So that was important for us. But we also joined forces with the HIV community. Those were the early days when people used to talk about the 3 H's, right? Heroin, heroin. What was it? God, I've forgotten the 3 H's there. But in fact, hemophilia was seen as not a very, kind of desirable disease to speak up for, because you were immediately seen as somehow being contaminated. So it was important. The community had to come together and to work across that disease. The other thing that became really important, and this was really for us, is getting the message out there into the public. I will say for hemophilia, the big break we got was when we had one single journalist. We did a press conference. One journalist showed up, the Globe and Mail, single newspaper. He took the story and he ran with the story. And because it was our national newspaper, one of the most legitimate newspapers, suddenly it went from being, this kind of an issue that nobody knew about, to being front page issue, being something that was not just that a number of people got infected, but is there a problem with the system? How did this happen? Our parliament took it up. There were then hearings in the House in which these, again, the journalists suddenly showed up and they began to cover this. And suddenly we were almost weekly in the news, front page news. And when we got an inquiry call, they followed us. I became sort of an interesting person in that, because I ended up being president of the Hemophilia Society. Even though I didn't have hemophilia, I became a spokesperson for them. And I think I became president because somebody says you mastered the 5-second soundbite. Because when the journalist comes up to you, when the TV camera's there, they stick a microphone on you. They want 5 seconds of what it was that happened there. And so that was it, right? And for me, it's been always a close relationship, between what we're doing in terms of advocacy and certainly, the ongoing continued coverage. I remember when we first discovered that so many people in Canada have been infected with hepatitis. It was a report, a scientific report, a study that had been done that was buried. Nobody wanted to show it. And we found it. And, we took it to two of our main media and said, we'll give you an exclusive if you print it the way we tell you to. And they did. So again, that led to, as I said, $1 billion lawsuit that ended up being compensation. But let me take it more globally, and I will kind of get off the personal end of it. It gave me the courage to leave the university and to quit my job as a tenured professor to become a full-time advocate. I will have to thank my husband for saying, go do it. You can, we're supporting you. We don't need you to, be doing, I didn't even have a job. I was just out there. But, over the time, came back into rare diseases and took on the chair of the Canadian organization. And then over time, as I said, we've built this into and working now internationally. I will just jump really further over. Probably the most important things we've been able to do over the last number of years is last year, 2021, we had the United Nations Declaration on Rare Diseases. This is a huge victory. It really identified rare diseases as a global issue and identified not just as a healthcare issue, but as an issue with regard to social injustice, with regard to economic disparities, with regard to occupational disparities, gender inequities. It brought together the issue and the call for countries to actually address rare diseases as, in fact, an important social issue. The other thing we've also been able to do is sign a memorandum of understanding with the WHO, so that we're not working in partnership now with the WHO, and we're hoping that we can expand that into a declaration with the WHO, which, if they pass it, will call on all countries to actually address rare diseases and call on, recognizing rare diseases as, again, a discriminated minority, which we got put into the universal health coverage. And we're hoping that some of that is what will help in many of the low and middle income countries, which are still struggling with, as we know, even just the identification of rare diseases, but recognizing that under that mantra, which I think we hopefully all agree with, and that is leave no one behind, means that you do not leave behind those with rare diseases. And the mantra also says, even in emerging healthcare countries, systems, even in countries that are low middle income, you cannot use that as an excuse for not addressing rare diseases. So, I think we really have been trying to, make sure that when we're talking rare diseases, we're also able to include everybody across the globe and really recognizing that everybody's working partnership together. But I will say is that I'm actually thrilled. I took part in the National Press series last year, and Britta, you probably know as well as I do. We have so few really good health journalists these days. Everybody's become something else, right? We used to have dedicated health journalists, and then health journalists that even understand rare diseases. They are actually quite rare. So the idea that we're going to have, journalists who are there who can pick up some of our issues and actually help us to raise awareness is such a great bonus. And really looking forward to how we work further.
Yeah, Durhane, I just hear here, first of all, for all countries addressing rare disease and its impact on the people of those countries. Here. Amen. We're going to circle back to some of the wonderful points that Durhane brought up about the impact that the media has had or could have on patient advocacy. And I agree that we really, the beauty of this program is to help the journalists with us here today to develop their interest in covering rare disease, because there are so many facets of rare disease that you could cover just a few of them over a lifetime and barely scratch the surface and never get bored. So I'd like to, before we delve a little bit deeper into that conversation, Christine, could you please introduce yourself and share with the journalists your journey and where you're coming from?
Thanks, Britta. Christine is my name. I come from Nairobi, Kenya, and I'm a mom to 2 kids with different non-related rare diseases. And stemming from that, my passion for creating awareness on rare diseases came about mostly because up to date, I've never found somebody else with the same condition as my kids in the country. And all the support I was getting was from outside abroad, actually, and not in Africa. So it was a bit of a challenge, I can say, from the beginning, because even in Kenya genetics then, because my firstborn is turning 16 in a few months, was not that common for everyone. So I have a small slide. Okay, that's my personal background. And from there, I started doing Rare Disease Day awareness from 2014. And that morphed, as Durhane said, it morphed into something bigger than we thought. It became more than a support group. It became a need for policy change, a need for including different stakeholders to help you raise that voice. And my presentation today will be on Rare Disorders Kenya. That's the organization I co-founded in regards to the rare disease space in Kenya. Let me share my screen. This is Rare Disorders Kenya. We're a patient-led organization for parents, patients, caregivers, basically anyone willing to help us raise a voice on rare disease in Kenya. And our aim is basically to bring in the different stakeholders from pharma, government, pharma, government, healthcare providers. That's ranging from clinicians to nurses, to anyone basically who has a stake in the healthcare industry for our patients. We have around plus 70 recorded conditions. And by this, I mean, these are the conditions that we have come across either through directly or from the national media houses. And then some of the quote end quote common rare disease examples we have is multiple sclerosis, myasthenia gravis, muscular dystrophy, that's both spinal muscular atrophy and Duchenne, narcolepsy. So these are the ones you find that at least there are more than 2 people in the country with it. So that's what we represent. Our objectives are quite simple: to educate and raise awareness, to improve lives of people living with rare diseases, to promote research, and to collaborate. The reason we have these objectives is because, as I said earlier, we're more than just a support group. We need to create a difference in this society that we live in. And for us, this is what we came up with as the objectives for the organization. And these are some of the photos of the events we've had before. The first one was a picnic site where we eat, we call it nyama choma. It's roasted goat. So that was where we had the first meeting. The people hugging is just one of our Rare Disease Day events. As you can see at the bottom, we're all showing love in sign language. So that was for just before COVID, the last Rare Disease Day event in 2020. Then the left photos, these are our poster photos for this current year's Rare Disease Day, and they all represent different conditions. From left to the lady, she represents Turner syndrome. The small girl represents I can't remember. The guy represents narcolepsy, and the guy on the wheelchair represents spinal muscular atrophy. So this is what was part of just to give you an image of what you've been up to. Then upcoming opportunities, we have an African Alliance that we're coming up. We are forming. These are different umbrella patient organizations in Africa coming together to create an alliance for Africa, to raise a voice for Africans by Africans, so at least we can speed up the process of rare diseases on the continent. Of course, there's a Rare Disease Day for next year, continuous medical educations with local healthcare providers, and also disease-specific awareness days for our members. Then these are our contacts, basically. So in a nutshell, this is what we've been able to achieve and much more. For the Kenyan journalists, I'd like to let you know about a technical working group for rare disorders that was formed by Ministry of Health late last year, that we are a part of, that basically is there to make sure that the government, the legislators, the policymakers know about what we in the rare disease space are doing. In a nutshell, yeah, thank you.
Wonderful. Thank you, Christine, for sharing your personal journey and how you've used that and put it in action while raising your children, while working to make to keep paycheck coming in. This isn't all of Christine's life. This isn't all of our lives that we share with you. I would love to share with the journalists to discuss a little bit here between you, Christine, and Durhane, how we've seen the role of patient advocacy evolve during our time and during our work. I mean, I know that over the years since those policies that I mentioned, particularly that Prescription Drug User Fee Act, that was a game changer in 2012. Since 2012, before I really even started engaging in advocacy myself, the tide was turning, that allowed for much more engagement directly with patients and families between them and the FDA. And industry, pharma and bio, was, have been now open to listening to the patient voice. And there's been many opportunities to have our voices heard during the first 5 years of that PDUFA Act passing. The FDA conducted 24 patient-focused drug development meetings. I mean, these are things that we never saw before, and especially with this frequency. So certainly as a community, it's just over the past decade has been a golden decade. Me personally, since joining the EveryLife Foundation 4 years ago, I've witnessed a steady growth in the number of advocates engaging and staying engaged and making their voice heard. More and more people turn up every year at our Capitol Hill, Rare Disease Week on Capitol Hill. COVID allowed for many more patient advocates to engage with the use of technology when they couldn't otherwise. Maybe they had many, of course, in our patient community, have limitations on their ability to travel. Not everyone can come to DC to make their voice heard. So suddenly, patient advocacy could be done from home. So there's been so many ways that our voices have been able to be heard. Durhane, do you have a few thoughts on that?
Yeah, so let me kind of take a slightly different slant on it again and sort of moving outside the US, as you say. I mean, the US has definitely pioneered the way, not just in the orphan drugs, but as you say, engagement with the developers and also engagement with regulatory in the FDA. But beyond that, of course, in many countries, the real challenge is getting rare disease policy. So it's getting diagnosis, so screening. And in the US, of course, you've got an amazing newborn screening program, but even that, as you know, is uneven across the state. So it's a lot of advocacy. In many cases, what we can't talk about is inside and outside advocates. Outside advocates are the people that sit on the steps. Outside advocates are the ones that are affected. They're the ones that put the pressure on. They're the ones that tell stories. They're the ones without whom absolutely disease has no face. But as I always say, and as we always say, you can be as good an advocate as you can outside. So long as you're standing outside the gate, nothing happens. You got to get inside the gate. You got to get to the table. And I think that's, again, where a lot of the advances have been made, right? As patient advocates become much more skilled, as they become much more informed about how the regulations work, how does legislation work, how does science work, how does industry work in developing the drugs, then we get inside at the table. And, and we do demonstrate, I think companies have been far ahead in people in terms of recognizing you've got to have informed, advocates at the table who are helping to design the drugs, design the clinical trials, decide what the endpoints are. But in the policy arena, it's been a little bit more difficult because they don't necessarily want to have the advocates kind of raising the need for additional funding, additional services, additional access to the drugs, right? But we've been able to demonstrate that when you bring people in and you're actually providing the right kinds of testing and services, you actually end up with much, not only better healthcare, but much better overall services. And a good example, I know, Christine, Samuel from Ghana. I mean, Samuel is a patient advocate. He also happens to be a doctor. But what he was able to do was to demonstrate that if you actually put in good screening and testing, you are able to catch patients. And, even now, about 50-60% of patients coming in pediatrics in emergency rooms will have a rare disease. And he demonstrated that if you caught them, tested them, you were actually able to keep them from being continuously coming back in again. It was cheaper for the system to actually address them and to actually be able to service them than it was to kind of ignore it. So I think that's where we learn to be at the table with good solutions, understanding how the system works, being able to provide those policy solutions. And hopefully, I think as Christine is saying, we now get to be part of the developing of the policies. We get to be part of the designing of how those services ought to be delivered and even helping to monitor it. That's our goal across the globe, is how do we get more and more patient communities? But it's a matter of getting the systems to open up. It's a matter of getting patients educated so they can absolutely understand policy and how to be at the table. But also, and again, let me swing back to who our primary audience is here. It's really a matter of having the media and the journalists to actually raise that awareness, to actually help us in terms of being able to, to document kind of what the impact is. So, huge, I think, and this is, in different levels, like the US is far and above, and the European Union is far and above where many other countries are, but we're all kind of moving in that same direction.
Exactly. Christine, would you like to add on to those thoughts?
I think Durhane has covered a lot of that, but as we're talking, since the audience is the media, I like the fact that that healthcare is beginning to appreciate patients and patient advocates as peers, as stakeholders in a patient's healthcare management system. So it's also, as the media is portraying, there's a healthcare provider, there's the patient, then they need to also make sure they've leveled up the patient to the level of the table, because they are at par. Because as I think James said in the previous presentation, and which is true, is that as patient advocates and patients who are living with rare diseases do get to know more about our own conditions than the healthcare providers. So we should actually be part of the conversation, not as a by the way.
Exactly. Yeah. And I was pleased with what you said, Christine. You said that since you started in 2014, that your organization has become more than a support group, right? That the journey goes from coming together and supporting one another, but then, okay, what do we do? How do we put this in action? And I think that's what we've probably all seen more and more over the years. And I'll also just make a note that patient advocacy has evolved for us on the state level as well. That we started out with Rare Disease Week on Capitol Hill. Well, now we have Capitol Days in the states, and we are developing advocacies and work and in each and every one of the states. That's a big shift.
It's also, as you say, though, Britta, is training up people to be able to do that, yes. Right? It's getting down to where people would have been parents and patients, but really, how do you understand state legislation? How do you know who your legislators are to be able to do that? And that's, I mean, the U.S. is, again, I think, really led the way. But can I give a plug for EveryLife Foundation?
You could do that any day of the week, Durhane.
You know what you folks have done for us as well is you've demonstrated the power of data, the power of evidence, the kind of surveys and the studies you've done. I mean, we all quote and use the EveryLife Foundation on the impact of rare diseases on patients' families, right? The cost of living with a rare disease. Mm-hmm. I mean, it's a different environment, the US, but those numbers translate, and it also inspires many of us to do the same. And I think what we recognize when you say the next level of advocacy is actually, and Christina, you know that as well, how do we get the information? How do we actually document what the impact was? And I go back to hemophilia. We got what we did because we were able to document the impact of what happened to people and how, in fact, how many people infected, how much it cost the system. And this is something that we have to increasingly do. So patients, yes, we have stories, but our collective stories actually become data. And those collective data then become powerful tools, right, that we can turn back into getting the action done. So part of it again is getting people who are trained in terms of doing that kind of data collection and analytics to work with it. So it really goes beyond, patient advocates, yes, but we have to now been able to work with so many others. And again, it's a global initiative. So I'm going to have to leave shortly to catch a plane. Can I do a quick plug for anybody's here? So I actually am president of the Asia Pacific Alliance of Rare Disease Organizations. If there are any journalists here who are in the Asia Pacific area, we're hosting a rare disease conference in Bangkok, 25th to the 27th of November. We would love to invite anybody who would like to join us to come. We would love to we're going to have patients, clinicians, policymakers, researchers, and industry from across the Asia Pacific region, from Australia, New Zealand, but also from China, Taiwan, Hong Kong, Japan, Malaysia, Singapore, Thailand, the Philippines, India, Vietnam. We're all coming together. And you know what the exciting thing is? It's being organized by the patient organizations. So really come and join us, because again, you can see patient advocacy in action and across a huge range of countries. I just wanted to get the plug in. And if anybody needs to get that information, I'm sure we can make it available on how to get there.
Excellent. Thank you, Durhane. And
Have
we
a
know
safe flight.
Yes, we know.
So I just want to say, Durhane, thank you so much. It's been a pleasure getting to know you. Safe travels, and we'll be in touch.
Okay, thanks a lot.
So I'd love to pick up on the what Durhane was touching on throughout her speaking, and that was the impact of the media that on rare disease. And Durhane mentioned how now patient advocates are quoting data such as the National Economic Burden of Rare Disease study that the EveryLife Foundation led. How is that happening? Okay, it's happening from us sending emails and communicating through social media, yes. But when this study first came out, we got a tremendous amount of media coverage. And that, hand in hand with our communications channels, is what has done what Durhane said. Now, I get emails quite frequently with people asking if they can cite that study, and they weren't on my email list, so they're getting that information somewhere. So that power, that amplification that journalists have for us to reach new audiences is quite powerful, and not only to reach new audiences, but also to reach existing audiences, so that our current patient advocates, when they see a story in the media, see a rare disease story, or the EveryLife Foundation that they're volunteering with and for, that gives them a lift. It emboldens them and keeps them going, right, Christine?
Yes, that's true. And then also the fact that positive journalism in terms of you're quoting EveryLife Foundation, you're quoting Rare Disorders Kenya as this go-to support group or patient organization for rare diseases. As journalists, you're creating a pathway for the patient. One of the presenters, I don't know if it was yesterday or the day before yesterday, showed the diagnostic odyssey. And in all that jargon, there was a patient advocacy group. And once that patient reaches that box, their healthcare begins to get streamlined, because we'll show them where the experts are, how to get in touch with the experts, how to get support, how to not go through this rare disease journey alone. So we are playing a big part. I think it's just that maybe we're not blowing our own horns too much, but we should, that the journalists should help us help our patients.
Christine, are there any opportunities that you see for the media, from things that you've witnessed, or that you think that the media could keep in mind?
Yes, and that is that I can start from when they're reporting a story, for example, like the one that was said for "This man smells like fish." See, that's a bit harsh. and it can create stigma. These opportunities could be best if, since they say they don't have a head start over the editor in terms of how to create a story, it's always good to get back to the patient. So they sort of story and then it's a hit and go. So they can always come back to the patient or the person giving them the narrative and tell them, look, this is how it's going. This is what is happening. This is what we intend to do with your story. Because I've found that a lot of journalists do not, I don't know if it's a practice, but they do not give you back the story before print. So you don't know what's going to go out there. Then patients come to us and tell us, but you told us they were going to talk about this. This is what I meant. But see, if there's no feedback between myself or the journalist or back to the patient giving their story, then it becomes a bit of next time they'll not be willing to tell their story.
Right.
So that's an opportunity that
Yeah, good points. I think sometimes that happens and sometimes not, depending on the journalist. And I know we're talking about things that and practices that our fellows on the line here are aware of, but I think it would be of interest to hear from us from our experiences in interacting with the media and how we've seen rare disease cover. I've seen so many incredibly powerful stories that have helped us move the needle forward. But there's such a great responsibility in covering rare disease because it's complicated and there's responsibility to get the facts right and try to avoid sensationalizing. I mean, I remember being excited at first when I heard that the TLC channel was running a documentary on a man with lymphedema, but it was because he had an over 100-pound genitalia that was impacted by lymphedema. And so that's why they were covering. It was the spectacle. It was the outlier. And I thought, oh, I'll give it a chance because this is any press is good press, right? When we get this, people will know the name lymphedema. Well, during that coverage, they did not correctly describe what lymphedema is. They indicated that it was simply a tumor that needed to be removed, which is so far from the truth. So that did not help to move the needle forward. In fact, it sets us back and makes us a spectacle and increases that stigma. However, that is not the rule, that is more the exception. I personally had a good experience with journalists when they were accommodating to what I was comfortable with. They were covering a story on the Lymphedema Treatment Act, and they wanted to come take pictures of me and come into my home and take pictures of me where I live and maybe getting dressed, putting my compression garments on, and I wasn't comfortable with it. We were also moving at the time, so it was a wreck. But they agreed to take my picture in front of my home instead, where they could still see my compression stockings and gear, but we weren't in a place where I wasn't comfortable. And so let's talk maybe a little bit more about this, Christine, with the sensitivities that journalists, we know they're aware of, but we just want to call out today, where patients and families, they may not know things like off the record or on background, right? Or they may not know to ask, hey, could I see my quote or any quotes that you use of
Christine,
me
before you answer, I need to jump in and remind our audience that we're coming to the end of the program, and I want to give the journalists a chance to perhaps answer questions as well. So, but please go ahead and answer that question, Christine.
Okay, for me, it would be consent. Like every time they know they're gonna do something, they alert the person giving them the story. So that, for example, if they're talking to me about my children, I can tell them, but they can let me know, this is gonna do this or go this way. Are you okay with it? Because as you say, not everyone is aware of what happens. So it would be prudent for them, since they know what happens in the office, to let me know these are the options I have. So are you comfortable with this? Yes, no. If not, can we do this? So by the time I'm telling my story, I'm relieved, I'm at peace of mind of what they're gonna come up with. Yeah, so consent is
Right.
something small, but it's very
Consent.
key.
Mhm. And Christine,
Yeah.
you mentioned to me the importance of using EQ versus IQ in these kinds of
Yes,
situations.
I
So,
did. Yes, I did.
yes, yes. So thank you for letting us share that, Rachel. We certainly want to hear from the journalists.
Britta, do you want to, all right, I guess I need to do that because I can see the Zoom hands raised here. I think 2 participants, let's see.
I'm sorry, I'm not a journalist. I am the mother of a little boy with an ultra rare disease, and I am also a scientist. So I'm pretty happy to say that I am able to sit at the table of researchers. That advocacy part is fine for me, but what I find I have struggled with over the past couple of years is actually getting the media attention. Rather it is, certainly there are different ways of telling a story, just like you were saying, Britta, and we don't want to, fall into sensationalism or anything, but I am just wondering, since the audience here is mainly journalists also, how I can get their attention. I have tried radio, I have tried press, and I just don't seem to, I don't know, bring the right angle to my story,
Let me jump in and speak on behalf of the journalists here, and that is one tactic that I always advise people is to, again, find out about World Health Organization annual days that might be connected to what your family is experiencing. Another thing, obviously, for you to keep in mind for next February is Rare Disease Week. And so that is an opportunity for you to start in mid-January, say, or even earlier, reaching out to local media and saying, I have an idea for a story or an angle that you can cover. I don't know if you were listening to our prior conversation, the prior set of speakers, but our one speaker mentioned the fact that the issue of heroism in this, and sometimes people who are in the thick of it don't necessarily think of themselves as heroes. They're simply doing it for the love of their child, their family member. And so that's sort of a removed concept. But I think that's another way to sort of have journalists consider that the extent of effort and energy that has to go into supporting people with rare disease is could be considered that. But I would say, again, another thing to keep in mind is to stay abreast of news events that, again, even if they have a sort of tangential connection to the situation or the health condition of your rare disease family member, you need to be prepared to really jump on that as an opportunity to do an outreach to local journalists. Is that helpful? Is it pronounced Tiffany or Tiffane, or how do you pronounce your name?
Stephen, thank you.
Good.
Yes, that's very helpful. Well, I actually tried at this year's Rare Disease Week. That's actually when I tried, and I intend to try again next year. That's okay. I'll keep trying, but definitely yes. Thank you.
Yeah, I would suggest rather, and this is not just because I'm plugging National Press Foundation, but you might want to watch some of the other sessions from this webinar once they are posted on our website and on our YouTube channel. That could also give you some insights into how to pitch story ideas or how to sort of tag them to other issues. Any other questions? Shiraz, do you have a question or is this a comment?
Yeah. I just have a suggestion which I just put over there. In fact, very remarkable presentations by all the three ladies. And it's very interesting to listen all of them, the way they're actually serving in their communities. In fact, supporting the patients, particularly also sharing their own experiences. So I was just in the question reply as thank you so much that you were also giving a good suggestion of how to cover it and how the journalists can actually give their attention towards the stories. But like one of the ideas also came into my mind, which I just shared over there, that in fact, like when if they are agree, so they can just share their details with me, so I can find out that if the same sort of a rare disease patient is available somewhere in Pakistan as well, so we can link with both the patients and their families the way what kind of facilities they are getting while in the different countries, and how in fact the families are actually facing problems and helping each other so we can connect them. And that would be a good international story as well.
I'm going to allow Hawk and Miller to have the last question before I turn it back over to Britta to wrap it up. Hawken?
Okay. Yeah. Thank you, everyone, for your time today. I was one comment to add before I get into my question is I think often what's not realized is that journalism, at least in the U.S., is very underfunded and under-resourced and underappreciated. So it is hard to cover all of these. But like, I'm grateful for the National Press Foundation to help kind of address these issues. But I wanted to ask, Britta, you talked about a rare disease center of excellence and legislation going through for that. I'm curious where that is at right now and how that would add to what the FDA isn't doing already.
Yeah, Hawken, well, first of all, thank you for your coverage in the past. You've really, you've helped to give voice and to reach to new and existing audiences through your thoughtful coverage. And what you may be referencing is perhaps the STAT Act and other policies that we've been working to push forward. And certainly we were pleased to see the PDUFA reauthorized recently. And we're going to be working more through the end of this Congress, it's not over yet, to get more aspects of the STAT Act and other policies advanced. And Hawken, I think this is a conversation I'd love to continue with you and perhaps our policy experts to really dig down into your question.
Great. Again, Britta, wrap it up before I close us out. Thank you so much for stepping into this role, by the way.
Well, thank you. I think that what Hawken said about the challenges and limitations from the journalist side of it is, we are very much aware of and appreciate. And I think it's just about finding each other in the right moment and forming these relationships so that when the opportunities come for journalists to cover these stories, that we as Typhane, I know I'm probably mispronouncing your name, that we are at the ready with the stories and the data to support these stories. So that's what it's all about. That's why I really appreciate Rachel bringing us together, and I would love to find more opportunities to do this.
So on behalf of all of the journalists, I want to thank Christine Mutena of Rare Disorders Kenya, Britta of EveryLife Foundation, and I want you to know that we will be reaching out to both of you moving forward for support and insight. And so we're so grateful for your participation. And that concludes the Covering Rare Diseases Journalism Fellowship Program. On behalf of the National Press Foundation, Foundation Ipsen, and the Evelyn Y. Davis Foundation, thank you all for participating in this very important training.